I'm Dr. P.C. Gupta, Head of the Department of Vascular and Endovascular Surgery, Interventional Radiology and Podiatric Surgery. A very unique department which provides all relevant specialists under one roof for comprehensive care of patients with vascular and related problems. In today's date, there is virtually no organ which is not treatable by some interventional methods. With me, I have Dr. Mustafa, who is an interventional radiologist and specializes in treating problems of the thyroid and parathyroid gland without subjecting the patient to open surgery. Now, the thyroid gland in the neck, it's a very important gland. It's virtually the engine of the body, which is responsible for functioning of most vital organs. And parathyroid glands are related to the thyroid glands, are very important for calcium and phosphorus metabolism. Now, quite often we see patients who have thyroid enlargement, parathyroid dysfunction. Now, what are the problems that we can treat with embolization or interventional methods?
So minimally invasive procedures like ablations nowadays in thyroid and parathyroid glands, we can treat all the nodules, benign nodules which can cause pressure symptoms, swellings, which can cause cosmetic effects, and also parathyroid nodules which can cause hyperparathyroidism. These can be treated in a minimally invasive way. They require no scars, no general anesthesia. It can be done in local procedure.
So, Dr. Mustafa, what are the specific nodules that you can treat by this minimally invasive method? And what are the nodules that you would not treat by these methods?
So coming to the thyroid, the nodules that we can treat are benign nodules. There is no cutoff of the size of the nodules we can treat. The larger nodules, for example, greater than 4 centimeters, if they are there, we require multiple sessions. Like, it can't be treated in a single session. But the smaller lesions, like 2 to 3 centimeters of lesions, they can be done in a single setting. The thyroid ones, those are benign and non-neoplastic. Small thyroid carcinomas, like papillary microcarcinomas are called, like 3 mm, 4 mm. Those can be treated with the ablations. The parathyroid ones, the parathyroid adenomas with a size of around 2 centimeters, they can be treated if they are visible on the ultrasound. If they're not visible on the ultrasound, we can't assess them or be precise enough to burn them. So those are the sizes. And so the takeaway point should be that benign nodules causing pressure effects, cosmetic effects in thyroid, and also some cases selected which hyperparathyroidism can also be treated with the microablation procedures. The most important thing is that if after thyroid procedures, ablation of the thyroids, we can treat them and we can manage them medically. The hyperparathyroid effects are less, and they don't need to be on a continuous thyroid medication, radioiodine therapy, etc. The scars will not be there, they will be mobilized early.
So, to sum it up, basically, we do not treat cancers except, as Dr. Mustafa said, very tiny nodules which are really quite often not picked up. But large nodules, small nodules, parathyroid, thyroid, they can be treated as long as we can see them on ultrasound. But we would avoid treating cancer with this method.
Yes.
Now, if a patient were to ask, how do you do the procedure and what is the advantage over routine surgery?
Yes, that's the most important point. The most important advantage of this surgery is early mobilizations. In the fast-paced life that we are having nowadays, the downtime of a post-major surgery requiring a scar and stitches will be around 6 to 8 weeks. In this procedure, the patient can be back to normal life in 2 to 3 days. Most of the patients that we do the procedure, ablations, even for thyroid or parathyroid, can be discharged the same day or the next day morning. And they can get back to their normal activities in 2 to 3 days. There won't be any scars. They will have some pressure effects or symptoms in the neck due to the local anesthesia and the hydrodissection. That is method in which we separate the important organs from the thyroid or the parathyroid to avoid any damage to them. For example, a recurrent laryngeal nerve palsy, that is the most common complication which can happen even with the major surgery, but with the precision of ultrasound and the hydrodissection, we can avoid that.
So let me just clarify this point. Now, recurrent laryngeal nerve, which supplies the voice box and if injured can result in hoarseness of voice.
Yes.
Are you saying that we can minimize the risk of injury to this nerve compared to open surgery?
Exactly, sir. We can minimize it because we can see the structures on the ultrasound and we can give a good hydrodissection to that. There is a possibility of having that, but with precision and with good training, I think it can be avoided.
Fantastic. I think that's a big advantage over open surgery when it comes to minimally invasive treatment of the thyroid and parathyroid. Now, after the procedure is done, and typically, as I understand, it's done under local anesthesia,
Yes.
unlike open surgery, which requires general anesthesia, what can the patient expect in terms of what would the patient feel? How quickly would the patient be able to go home? How quickly would he or she be able to return to normal activity?
Yeah. So post procedure, as we know that during the procedure, we'll insert a needle that is called an antenna into the gland under ultrasound guidance, and we'll burn it. So during the local effect of the local anesthesia, the patient should be fine. After the procedure, he'll have some tightness that should be easily manageable with medications, like any pain analgesic, anything like that. After the procedure, we'll follow the patient. For the parathyroid, we'll follow the patient with parathyroid hormone levels, serum calcium levels, and the ultrasound screening. Similarly, with the thyroid nodule ablations, we'll follow the patient with the routine ultrasounds in our OPD, and any lab work that should be required will be done.
Yeah, I think it's important, like in the department we work as a team, for these problems we also team up with the endocrinologist who typically manages the thyroid
Yes.
and parathyroid problems,
Yes.
so that the patients get the best.
Yes.
So what I can see is that minimally invasive ablations for thyroid and parathyroid are really changing the landscape when it comes to treating patients with thyroid nodules or hyperparathyroidism.
Yes.
Thank you, Dr. Mustafa.
Thank you, sir.
Thank you.